Is yours.
Thank you, sir. Good morning, everyone. Well, I'm here to talk on pre-planning, patient selection, and corneal marking. Well, about 10% of our patients whom we do cataract surgery have astigmatism of more than 2 diopters, and about 20% have astigmatism between 1 to 2 diopters, and even 70% have less than 1 diopter. So the options available for these patients are more than 1 diopter. The obvious answer is toric IOLs. Less than 1 diopter, we can consider limbal relaxing incisions. But you can see here that nearly 30% of our patients whom we do cataract surgery need toric IOL. But in reality, every 4th case that we do, we don't implant a toric IOL. But when we prescribe glasses, even 0.5, 0.75 or 1 diopter, we always believe in correcting the cylinder. But the same, we don't do it when we plan surgery. The reason being, one is the cost factor. Of course, MNC companies charge about 15 to 16,000, but off late, Indian implants, which are brilliant, is available just for about 5 to 6,000, which gives quite predictable values. And the second is fear factor, which is the aim of our IC to negate. Well, the quality of vision deteriorates quite significantly in astigmatism. You can see here that just a 1 diopter astigmatism causes vision loss quite significantly. Even the 660 appears quite blurred. So why consider toric IOLs? Well, they are quite reliable, predictable. Unlike other so-called premium multifocals, they don't have the unnecessary glare halos or the dysphotopsias associated with it. And it is, of course, the most accurate way of correcting pre-existing astigmatism. Patient selection criteria, it's always essential to rule out any irregular astigmatism. The steep and flat meridians are 90 degrees apart. If we have access to a corneal topographer, better to do a topography to ensure that the astigmatism is symmetrical. Contraindications include irregular astigmatism, keratoconus, unreliable measurements we get in certain conditions like dry eye or keratoconjunctivitis cases, and progressive corneal diseases which include Salzmann, Terriens also. And of course, prior keratorefractive procedures, we should be careful when we do a keratometry. So factors to consider include location of the cylinder as well as age of the patients. Because all of us know most patients shift from with the rule to against the rule over time. That is towards a plus cylinder at 180 degrees. So for younger patients, it is always better to be less aggressive when we aim to correct with the rule cylinders. So SIA, how significant it is? Nowadays, most of us do phaco and the incisions that we put is less than 3 mm. So this is a statement by Dr. Warren Hill that if your incision is less than 2.8, provided the architecture is good, and if it is a temporal incision, we can take 0.2 as our surgeon-induced astigmatism. But this is not the same for superior sections. If the same incision is made superiorly, he says that the amount of astigmatism that we induce is about 1 diopter, which of course is significant. So rule number 1, when you consider torics, please shift to temporal incisions so that your SIA is lesser. And this is one of the most important prerequisites for toric IOLs. Biometry should be precise, predictable, as well as repeatable. So how significant is this keratometry? K-value difference of just about 0.2 mm can cause an IOL power difference of about 0.5. So what is really needed is just a simple and accurate manual keratometer is all that is needed to do good keratometry. Prior to do keratometry, ensure that your keratometers are calibrated, adjust the power based on the user's refractive status. Small things give rise to stacking errors, so all these to be avoided. And then what we should not do before keratometry? Please do not apply paracaine or do an applanation tonometer and then take the patient. This was one of our patients whom we did an applanation and then took him up for keratometry. You can see here the Myers are totally distorted and we were not able to get values. With regards to dry eye, this was one of our patients who presented with a dry eye, and you can see here as the patient keeps staring, the Myers get blurred and we were getting irregular values. So in these cases, take the patient off, put a 0.5% CMC, wait for some time, ensure that the corneal clarity or the wetting improves, and then go on to do your keratometry so that you get much more accurate values. Positioning the patient is very important. Ensure that the chin rest and head rest are proper. Do not put a speculum because you'll cause dryness of the cornea. Tell the patient to blink frequently. And this is something, a technique that I learned from my mentor. All of us will know that in our manual keratometer, there is a plus symbol as well as a minus symbol that we need to align. The plus symbols are quite easy to align. You can see here the small plus and the bigger plus are there, which can be just put on one above the other. This is quite easy. But with the minus, it is not that very simple. You can see here, this is what we really aim. The small minus should be exactly in the center. But here, because of the color difference, it is so glaring. But in a real scenario, both are kind of that yellowish green, so you won't know whether it is to the left, to the right, or to the center. So how do we get out of it? It is to check, to align your plus first, get your values, rotate the whole keratometer by 90 degrees, so that again you align the plus symbols so that you are far, far more accurate. Again, we are aiming at preventing stacking errors. So in a manual keratometry, it gives a lot of values to us. Look for irregular, wavy, distorted Myers and pulsating Myers, which we get to see in keratoconus cases. Is a topographer mandatory for toric IOLs? Of course, it is brilliant for axis evaluation. With the proper slit lamp evaluation, refraction, with the manual keratometer, we can actually do a pretty good job. Topography is not mandatory, but of course, it is an added advantage. Axis marking can be done freehand or with using a slit lamp. You can see here, you can see 3 lines which are hardly about 2 mm apart. But which of the 3 is right? The one on top and the one down will give us totally wrong axis values. So this is the best way of checking, of calculating, doing the marking. We prefer to do it on slit lamp. Put paracane, put a speculum, talk to the patient and make them understand what you're doing. Make a very thin, narrow slit, align the Purkinje-Sampson images of the slit lamp and the beam so that they're perfectly aligned. Using a 26 gauge needle, you can comfortably do a marking. And after doing the 90 and 180, you can take the patient to the theater and then do the final marking. The other option is, even using the same slit lamp, we can go as accurate as 2 degrees by using the markings present on our slit lamp. As accurately as 2 degrees, we can do the marking. This is something very important. Keep the cornea dry, shift the patient to the OR, and then enhance the marking using your conventional toric markers so that you're able to do the case comfortably. So the bottom line is, all the fancy gadgets are not really mandatory to do toric lenses, IOL Master, LensStar, or the Callisto. A good manual keratometry, A-scan, proper slit lamp examination, and a good technician is all that is enough to do comfortable toric IOLs. I'd like to thank AIOS Scientific Committee, my mentor, Arul sir, for this amazing and wonderful opportunity. Thank you.